Welcome to Deuk Spine Institute. I'm Dr. Deuk Majan, CEO and founder. Our patient has facet joint pain as the cause of her back pain. We're going to be treating her facet joints shot on the both sides, right and left. Go ahead and inject there. And the way we do this at Deuk Spine, we do a novel treatment called the Deuk plasma rhizotomy. It's not available anywhere else in the world. And what we're doing is going in and destroying pain nerves to the facet joints. That is the goal of every rhizotomy, known as radiofrequency ablation, that you guys hear about, RFA, in the pain management world. But RFAs don't actually do a permanent fix. They're temporary. And RFAs don't work half the time, and the other half that they work, they're temporary. So we developed a permanent fix for facet pain for patients suffering with facet pain. And that permanent fix is called the Deuk plasma rhizotomy. Now the target is the same as an RFA. We're aiming for the same spot because after all, the pain nerve hasn't changed. It's the same pain nerve. But what's changed is how we destroy it. And we use a more effective technique to destroy that pain nerve. We use a technique that actually does work. And it's called the Deuk plasma rhizotomy. Henry, let's show the audience how the Deuk plasma rhizotomy works.
Of course.
Facet joint injury is a common cause of chronic back pain. The inflamed facet tear generates pain signals. The best treatment for facet joint pain is the Deuk plasma rhizotomy. Inflamed facet joint pain nerves are destroyed. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Welcome back. You can see from our animation how this procedure works. We are destroying pain nerves. See the target right there? Show us, Jordan. I want to show you where my probe tip is, okay? It's called the Deuk plasma wand. And show us the pedicle. See the circle? Pedicle. It looks like a clock face. And then to the right of it is exactly where the nerve runs. There's the transverse process. And if you go to the superior border of the transverse process, that's right where my probe is on that picture. And that's exactly where the medial branch of the dorsal ramus pain nerve runs. Okay, so I just got through destroying that one. And next we're moving on to the next one. Any questions?
No current questions, but we do have a comment coming from George on YouTube saying the bone resection during an endoscopic interlaminar decompression is not that much. We just increased the window. It's millimeters. No increase of fracture.
Yeah. All right, George, I appreciate your comment, but you're still taking bone out. And I'm sorry, but you're also removing part of the facet joint, so you're violating the facet. It's impossible to do an intralaminar approach without removing part of the facet. So you're destabilizing the segment, period. And you can't argue that because it's true. Why destabilize the segment at all? Okay. But George, I appreciate your comment, but it's not possible to get to the disc without removing part of the facet. So you may be taking very little lamina, but you are taking facet. And George, I don't know who you are, but it seems a bit disingenuous. This is exactly what I've been telling people about. is surgeons are always trying to make it sound like their treatments are so great when there is a better treatment out there. This Deuk laser disc repair is that better treatment. Yeah, you may be better than an open microdiscectomy. I don't deny you that. You are probably correct. However, there's still better technology out there, which is my treatment, the Deuk laser disc repair, that removes 0 bone, 0 ligament, and 0 destabilizing long-term effects on the spine. So why go with second best when you can have best? I need to do one more incision, but I could probably do it for the sacrum. All right, we're done on the right. Now I'm going to go to the left side, and I'm going to just come over there just to make it easier. So I finished the rhizotomy, the Deuk plasma rhizotomy here on the right side, and I'm going to now go to the left side. The other thing is a lot of these endoscopic surgeons that use the translaminar approach, they also use what's called a biportal technique. So they're not just using one port, they're using 2. So they've got to actually come in from 2 places. All right. Shot. Well, why would you want 2 ports when you can do the surgery with 1? Does that make sense? So I wouldn't want 2 incisions and 2 paths to my spine. That's twice the trauma that's happening. And their ports are usually bigger than mine. So there's a larger port, double port, 2 ports instead of 1. And they're removing bone, and more importantly, they're removing facet joint, as well as some of the ligament. They're removing some of the ligamentum flavum. They're removing some of the interspinous ligament. They're removing facet capsule, facet foraminal ligament as well. And all those are stabilizing structures. Shot? All right, I'm going for my first target here, which is the left L2. Shot? I know I'm a little bit too high. Shot? I should be right on it there. Yes, I am. Yep. And again, you can see the anatomy. Can you show them the anatomy there? You can see the pedicle, he's circling, and you can see the transverse process. You can see the top of the TP and the bottom of the TP. You really want to be kind of at the top, where the top meets the superior facet, which is where I'm at right now. Shot. Yeah. That's right on the facet there. And there's the junction. Again, the target is the same as has always been with the RFA procedure. The difference is I'm using more energy, and I have a wand so I can move it around to destroy the pain nerve and slice through the pain nerves. Hold on. That's why our treatment works and other treatments don't.
We have about 2 questions.
I'll take them.
First one coming from Lanu on YouTube, asking, this patient had so much herniations. Were she tempted to have a fusion in the past? Just curious.
Sean? You know, the truth is that has she gone to another surgeon who was more aggressive, they would have recommended a fusion, multi-level fusion. Sean? But she came to me, and I told her, you don't need a fusion. You just need the Deuk laser disc repair. Shot? Because a fusion is unnecessary to treat her pain source. The source of her pain can be fixed without fusion. Shot? I'm just feeling around, by the way. I'm feeling the transverse process. You've got to make sure you're burning in the perfect spot. And it can be very easy to get confused where you are and then you're really going to hurt the patient. So it's important for those of you out there who are considering treatment, you go with somebody who knows what they're doing. Now, I've done 1,000 patient spinal fusions in the lower back, and countless laminectomies, countless discectomies, literally thousands in my career. So in that time that I did open surgery, man, I saw everything. I saw all these bones and joints and ligaments. I saw it all with my own eyes, and I operated on those areas. And I know what they look like. I know what they feel like. I know how they respond to intervention, like what I'm doing right now. So it's important that your doctor have experience with these treatments and not just go to somebody who's local and you're hoping that they're going to do a good job for you. You understand? You need to travel and go to where you're going to get the very best care, and that is right now Deuk Spine Institute. Don't compromise for second best. Second best has issues and problems. Second best is always going to be second best. And there's a reason it's second best, and it's not a good reason. Not good for you. The truth is, doctors need to know when they're able to treat the patient properly or not. And you really want to go to a doctor who treats the patient properly. Okay? Because you got one shot to get it right. And you don't want to have problems afterwards. You really want to try to get it done right the first time. So my dad always told me, do everything right the first time, you don't have to do it again. That said, of course, we have patients that do come back because they have pain from some other source. And we have to operate on them again and do something else. But generally speaking, our treatments are successful the first time. All right, we're going to move on to the SI joints. We'll be back. Any questions?
Yes, we have a question coming from Jack on YouTube asking,
Jack.
Doctor, for a very accurate diagnosis for a multifactorial case, what is the best step forward?
So Jack, the best diagnostician in the country for back pain is me, okay? And probably the world. And there's a reason for that, and it's very complicated, but your best chance of getting a diagnosis is to fill out the MRI review form and do a Zoom call with me. If I cannot diagnose your pain, I will tell you, I can't diagnose your pain. I need you to come here to our clinic. And if you come to our clinic, we'll be able to diagnose the pain. But there's two things we need. Number one, I need you to have the pain when I examine you. You must have the pain. You cannot take pain pills or cover it up in some way. You must make the pain happen so that when I examine you, I can identify the actual source of your back pain. And source is plural. Remember, the average patient with chronic back pain has 4 causes of back pain. 4. That's 4 distinct things. Could be 2 discs, could be an SI and a piriformis, could be 2 discs, 2 facets. But the number of patients with one cause of their back pain, say 1 disc, is less than, is basically 8%. 8% of 5,000 patients we studied with chronic back pain, 8% had one cause of back pain, okay? And those 8% with one cause, we treated that one cause and their pain went away, 100%, okay? But 92% of patients with chronic back pain have more than one cause. Therefore, if you treat just 1 disc, which is what most spine doctors do, they treat 1 disc or 1 facet. Guess what? 92% of the patients are still going to have pain with that treatment. So it's important. We started on the SI joint. We got to end the stream. We got to start the SI. So it's important that you get the right diagnosis. So do the MRI review. We're done with the facets. We're going to